Good morning, everybody. It's a real pleasure to be here in Australia, in this wonderful city of Brisbane. And I would like to thank the organizers for asking me to give this talk today. It's a real honor. And it is an interesting topic and still controversial. So as you know, there has been a dramatic increase over the last couple of years in bacterial STI incidence in an era where we have very effective drugs for treatment and prevention of HIV. And according to WHO, in 2021, there has been more than 374 million of new STI diagnosed. And as you can see on this map, it's spread across the world. And these STIs have had a profound impact on sexual and reproductive health, in particular in women. I will focus my talk today on 3 bacterial STIs: gonorrhea, because there is an increased threat in terms of antimicrobial resistance; syphilis, because of the resurgence of congenital syphilis; and chlamydia, because of the risk of LGV proctitis among MSM. And even if everyone who has sex can develop an STI, there are people that are more affected than others, in particular young individuals, gay and bisexual men, pregnant women, and ethnic minorities, and this is particularly true in Australia. Thanks to PrEP, there has been a renewal interest in STIs because people on PrEP are frequently tested for STIs, and they have also been diagnosed with a lot of STIs. And in this study, which was carried out in Australia, among participants and being enrolled in a PrEP cohort, the investigators looked at the incidence of STIs in people in the year before entering the cohort and after a year. And as you can see on the top row, the incidence of STI in the year before entering the study was already very high, 69.5 per 100 person years of follow-up. And this incidence increased to 98.4 after 1 year, with an adjusted incidence rate ratio of 1.12, which was actually mostly due to people who entered the cohort when they were not on PrEP. Interestingly, when you look at the distribution of participants and STI diagnosed by the number of infections, you could see that not everyone developed an STI during follow-up. And actually, a minority of participants, 25%, accounted for almost 2/3 of all STIs. And this is to keep in mind when we will have to target our preventive strategies to people most at risk. And, you know, what are the different tools we have today available to contain the STI epidemics? So we have the classics: abstain, be faithful, and condom use. And we should continue to promote the use of condoms to reduce the incidence of STIs. We could also recommend some behavioral changes, such as a reduction in the number of partners. The test and treat strategies in modeling studies has been shown to also have an impact on the incidence of STIs. Partner notification and treatment has yielded inconsistent results in terms of public health benefit. We are lucky enough to have good vaccines for viral STIs, but we are still waiting for vaccines for bacterial STIs to become available. And then we have antibiotic prophylaxis. Is antibiotic prophylaxis a new strategy? No, it's not. And it's been used since the 1940s, in particular in the army, to prevent gonorrhea. With the first antibiotics, we had sulfa drugs or penicillin. But the problem was that with Neisseria gonorrhea, these bacteria was able to develop resistance very quickly after these antibiotics were introduced. And this was true for all the other consecutive antibiotics that were developed to treat gonorrhea. And the threat today with Neisseria gonorrhea is to have an organism that may be resistant to all antibiotics. And it is a bacteria that is on the WHO priority list for that reason. There are different types of strategies when you talk about antibiotic prophylaxis. There have been a few studies looking at daily prophylaxis with doxycycline. We also used periodic presumptive treatment, in particular in female sex workers who receive monthly doses of azithromycin to reduce STIs. Mass drug treatment with antibiotics has also been used in geographically defined area on a relatively short time period to try to reduce also the burden of STIs. But all these strategies have been abandoned because of a limited effectiveness. And today I'm going to speak about post-exposure prophylaxis, which is in some ways treating incubating STIs. We have a good example of post-exposure prophylaxis with syphilis. And in a study that was carried out more than 50 years ago, the investigators wished to assess whether people who were contacts of someone diagnosed with syphilis could be treated to prevent syphilis to occur. And these participants were in contact with someone diagnosed with syphilis in the 30 days before diagnosed, were randomized to receive either penicillin G procaine or a placebo. And as you can see in the graph here, those receiving placebo, 30% of those developed syphilis, and none of those who had penicillin G. And so today, the US CDC recommends this presumptive treatment of sexual contacts of a person who has been diagnosed with syphilis, even though serologic test results are negative. And because we've seen such a high rate of STI in people using PrEP in our studies in France, we wish to assess whether doxycycline prophylaxis could reduce the burden of STIs. Why did we want to test doxycycline? Because there is no known resistance today to doxycycline in chlamydia, trachomatis, and treponema pallidum, which are the two main organisms we wish to target with doxycycline PEP. Doxycycline PEP has also been used successfully for the prevention of Lyme disease and leptospirosis, which are caused by organisms very similar to the one which causes syphilis. Also in France and in other countries, the use of doxycycline is somewhat limited to the treatment of acne or malaria prophylaxis. And in addition, Neisseria gonorrhea in France is already quite resistant to doxycycline, with a high prevalence of resistance up to 65%, with up to 20 to 30% of high-level resistance due to the acquisition of the tetem plasmid. So in the setting of the IPERGAY PrEP trial a couple of years ago, we tested whether doxycycline PEP, given as a single dose within 24 to 72 hours after sex, would be able to reduce the incidence of STI. And in this randomized open-label trial, the participants were randomized to receive either on-demand PEP or no PEP. And we wish to limit the antibiotic pressure by asking people to take no more than 6 pills per week. And in fact, the participants took only a median of 7 pills per month, so no more than 2 pills per week. And what you can see on this graph here is the incidence of the first episode of STI in red with no PEP, in blue with PEP. And you can see that the hazard ratio was 0.53 with PEP, so a nearly 50% reduction of the incidence of a first STI. And this effect was mainly seen because of the strong impact on chlamydia incidence with a hazard ratio of 0.3, so a 17% reduction, and a similar reduction in the incidence of the first episode of syphilis with PEP with a hazard ratio of 0.23 to 7. There was no strong or significant impact on gonorrhea in this trial. And these data were confirmed and extended in a recent study published by Ludger Meyer and colleagues in the New England Journal of Medicine a couple of months ago, in a study in which they have enrolled more than 500 participants, which were MSM and transgender women, either on PrEP or living with HIV. And in this trial, using a similar design, doxy-PEP versus standard of care, they were able to show a strong reduction of STI incidence with, as seen on the table, a reduction of almost 65%. And if you look at individual STI, you could see that the reduction was stronger with chlamydia and syphilis, with a decline in incidence in the range of 80 to 70%, but they were also able to show a significant reduction at the top here in blue of gonorrhea incidence by nearly 50%. In the DoxyVac trial, and we reported interim results at CROI earlier this year, we also reported a strong impact of DoxyPEP in the time to a first episode of chlamydia or syphilis with a hazard ratio of 0.16, so a nearly 80% reduction of the incidence of both STIs. Unfortunately, in another study reported at CROI by General Stewart and colleagues done in Kenya among young women and PrEP, they were not able to see a significant impact of DoxyPEP on chlamydia incidence. And you could see that although there was a trend towards a reduced incidence in chlamydia, this trend was not significant. So the investigators looked at the reason why DoxyPEP in this particular trial was not shown to be effective. So they first looked at tetracycline resistance in chlamydia by doing genomic testing, looking for the TET-C resistant gene in the positive PCR swabs, and they couldn't find any. All tested isolates were actually free of this TET-C gene. So resistance was not the explanation. The adherence, at least self-reported adherence, was also very high. So then the assumption was maybe the PK of doxy would be different in men and women. But also at CROI, Rich Hallen and colleagues from the CDC reported a very nicely done PK study among men and women assessing doxycycline plasma concentration and also concentration in rectal and vaginal secretion after a single dose of 200 milligrams of doxycycline. And what's shown on this graph, where you have in green the MIC90 of chlamydia trachomatis, was that with a single dose, you could achieve, over the next 2 to 3 days, very high concentration in both plasma, rectal, and vaginal secretion, which exceeded by 10 to 20-fold the MIC90 of chlamydia. And when you look at vaginal and cervical tissue concentration at 24 hours, the concentration are also 4 to 6 times higher than the MIC90. So these data would suggest that the concentration of doxy in the female genital tract were high enough to provide effectiveness. So we have still to understand why this trial failed in young women and PrEP, and we are looking forward to seeing the data on drug concentration in these young women. In the same study, gonorrhea incidence was not affected by DoxyPEP. But here there is a good reason, because when the investigators looked at tetracycline resistance in the isolates from the study, the Neisseria gonorrhea isolate, they looked at genotypic testing, and they found that all isolates carried the tetem plasmid, which is associated with high-level resistance to gonorrhea. And in the DoxyPEP trial done in the US, there was also an increased rate of tetracycline resistance in Neisseria gonorrhea isolates in the DoxyPEP arm as compared to the standard of care arm. And these data suggest that DoxyPEP may be less protective against Neisseria gonorrhea strains when there is doxy resistance. But in this trial, the number of isolates tested was quite limited. So it is interesting to go back to a study done a number of years ago assessing the use of another tetracycline antibiotic for PEP to prevent gonorrhea. And in this trial conducted by King Holmes and colleagues, where they tested minocycline among Navy men, they actually randomized more than 1,000 men to receive oral minocycline 200 milligram or placebo after sex, a median of 8 hours after sex. And when these men were at sea, the rate of gonorrhea was reduced by half in those receiving minocycline. But the isolates from patients given PEP were more resistant to tetracycline than those given placebo. And in addition, as shown on these graphs, you could see that the efficacy of PrEP was related to the Neisseria gonorrhea MIC. The higher the MIC, the lower the effectiveness. And because minocycline was also used for treatment of these people with a high failure rate, the strategy was felt to be of limited effectiveness and was not carried out further. And indeed, with Neisseria gonorrhea, what is feared is a selection of strains that not only would have increased resistance to tetracycline, but also to other antibiotics, and in particular to ceftriaxone, which is the treatment of choice today for Neisseria gonorrhea. And a recent study conducted by Mortimer and Grad looked at genomic and antibiotic susceptibility of more than 5,000 Neisseria gonorrhea isolates. And they looked at co-resistance for other antibiotics. And what you have on this graph is Neisseria isolates in different groups. Those who are susceptible to tetracycline with the letter S here, those with intermediate resistance, those who are resistant, and those with high-level resistance. And what they reported was that isolates who were resistant were also co-resistant to other antibiotics, and you could appreciate that the MIC to penicillin, ciprofloxacin, ceftriaxone, and azithromycin were higher in those isolates resistant to tetracycline as compared to those who were susceptible. But if you look at isolates which were highly resistant to tetracycline, this type of resistance, which is due to an encoded plasmid, the tetam plasmid I was alluded to earlier, then you have less co-resistance to other antimicrobials, and in particular to ceftriaxone here, where you could see that the MIC is actually lower than in resistant isolates. So when we will use doxy-PEP, it's going to be important to monitor genomic resistance to tetracycline and to see whether doxy-PEP will select plasmid or chromosomally encoded resistance. What about the other STIs? Well, for chlamydia, there is no stable tetracycline resistance so far identified in humans. But chlamydia suis in pigs has become highly resistant to tetracycline because of the acquisition of a gene, TET-C, which encoded an efflux pump, which actually expel the antibiotics from the cells. And in vitro, it has been possible to transfer these genes from chlamydia suis to chlamydia trachomatis when there is co-infection. And there are rare human cases of infection with chlamydia suis in pig farmers with conjunctivitis or asymptomatic infections. In addition, with chlamydia, there is a challenge to detect resistance because of the low sensitivity of tissue culture, and you need to do genomic testing. For Treponema pallidum, we know that we haven't seen any resistance to either penicillin or tetracycline, although these drugs are being used for treatment for more than 6 decades. But we know that a single point mutation in the ribosable RNA was enough to induce high-level resistance to azithromycin, which is now widespread. So the fear is that a single point mutation in the 16S rRNA gene could potentially select for tetracycline resistance for Treponema pallidum. In addition to the impact on STI resistance, tetracycline PEP could also impact the microbiome. And in the doxy-PEP trial, the investigators looked at the impact of doxy-PEP on Staph aureus colonization in throat. And what they have shown here, and it's shown on this slide, was that with doxy-PEP, during follow-up in green, there was a 14% reduction in the rate of Staph aureus colonization, which is a good thing. However, when they looked at the rate of doxy resistance among the Staph aureus isolates, they show a small but significant increase in tetracycline resistance. So this has to be watched. In the DoxyVac trial, we also looked at the impact of doxy-PEP on the microbiome. And you have here in blue the rate of ESBL E. coli detected in anal swabs in people receiving doxy-PEP or no PEP in red. And what you could see at baseline was that the rate of ESBL E. coli in people on PrEP experiencing a lot of STI was already very high, 30%. But this rate over time didn't change significantly with or without doxy-PEP. An interesting study was also presented at CROI earlier this year using a large database of the sexual health clinic in Boston, the Fenway Health Clinic. And the investigators looked at different doxypep prescribing scenario to try to see how to minimize exposure and to maximize the benefit of doxypep on averting STIs. And you can see that if you treat everyone, you would avert 70% of all STIs in green, but of course you would have a very high selective pressure on this population. However, if you focus and target your doxypep strategies to only those who had had 2 STI in the past 12 months, you would only treat 14% of these people, and you would avert up to 23% of all STIs. And if we have to use doxypep in the near future, we probably want to target MSM and transgender women living with or without HIV, those who have sex with casual partners without regular use of condoms, those who have had a history of at least 1 or 2 STIs in the last 12 months. I think it's important that these people, before starting doxypep, would be tested negative for chlamydia, gonorrhea, and syphilis, and that they have no contraindication to doxypep use. And possibly we should avoid this strategy if people have contact with pig to avoid dual infection. Doxypep would be used as a single dose of 200 milligram of doxy. Would be preferable to use the monohydrate because its GI tolerability is probably better. At least within the first 24 hours, but no later than 72 hours following condomless sex. And probably we should restrict its use to 1 to 3 times per week at most. And then if we do that, we have to monitor doxypep. We have to test these individuals at least every 3 months for STIs to assess doxypep safety, although the safety of doxy is pretty good despite some GI tolerability issues or photosensibility. And we have to perform tests of cure, especially if doxy is used for the treatment of STIs. And what would be critical would be to monitor antimicrobial resistance in case of breakthrough infections, doing both phenotypic and genotypic resistance monitoring. So in summary, we have today consistent data from at least 3 large trials showing short-term benefits of doxypep among MSM and transgender women with a strong reduction of syphilis and chlamydia incidence. The impact of gonorrhea has been seen in some studies, not all of them, but is likely to be limited in the future. Doxypep is well tolerated, highly accepted, and the adherence to doxypep is quite high. But there are long-term uncertainties with these strategies. So we have to be cautious, and we have to continue research on the use of doxypep because of the fear of selection and clonal dissemination of more resistant STIs, and because of the potential impact of the microbiome. So it might be time for cautious implementation of doxypep. We have to clearly identify the population who will benefit the most from this strategy. We have to monitor antimicrobial resistance and the impact of the microbiome. And critically, we have to involve all stakeholders in the discussion, the microbiologists, the expert in public health, the ID physicians, and more importantly, the community. And with that, I'd like to close and thank the couple of colleagues who agreed to share their slide to put out this presentation, my team in Paris, and the different sponsors, and in particular the ENRS in France. Thank you for your attention.